Good morning, everybody. Now, it's my proud privilege and honor to chair this session on connective tissue disease to be delivered by none other than Professor Handa, Rohini Handa, a prolific speaker and author of several books and chapters on rheumatology. Now, he needs no introduction, however. Let me give a brief introduction. He was a past Dean of Indian College of Physicians in 2017, President of APLAR. Please mute. President Indian Rheumatology Association, President APLAR from 2010 to 12. He is a recipient of Netaji Oration, Sarle Oration, API Oration, IRA Oration, Basanti Devi Amarchand Prize, and Emenson Oration of the ICMR, Pavan Kumar Jain Oration, and GB Jain Oration. He has about 335 papers to his credit and abstract in books and chapters. And he was a former professor of medicine and rheumatology, All India Institute of Medical Sciences, New Delhi. Now, today's topic is a very interesting topic, that is a case-based discussion on connective tissue disease. Now, this connective tissue disease, previously erroneously called a collagen vascular disease, which included rheumatoid, vasculitis, and musculitis. But specifically, it has about 4 phenotypes, which Professor Handa will deal later on. The prototype is SLE, systemic sclerosis, undifferentiated connective tissue disease, or MCTD, and Sjogren. And I will ask all my junior PGTs to please go through a book on clinical rheumatology by Professor Handa. This is the book written by him. He has written a very lucid chapter on this connective tissue disease. And now I will ask Professor Handa to please start his lecture.
Thank you very much for the kind introduction. Friends and colleagues, at the outset, I would like to thank Professor Amal Banerjee for inviting me to speak at this forum. Professor Sarkar, Professor Ganguly, and I can see Dr. Karmarkar and other distinguished colleagues. I extend greetings from cold and wintry Delhi. It's almost freezing cold, but we look forward to an interactive session. And I have been tasked with a case-based discussion, and I chose connective tissue disease. And let's get started. Please do type your questions in the chat box, and I'll be happy to take up questions at the end. Now, this is the story. Are my slides visible?
Yeah.
This is the story of Mrs. MD, a 41-year-old lady who was referred with complaints of joint pains and skin rash for 8 to 9 years. And these are our clinical photographs. This rash appeared and disappeared, was accentuated by prolonged standing in the kitchen, non-itchy rash, and usually occurred on her legs and thighs. The upper limbs and the face and the trunk were spared. The patient denied any bleeding from any of the orifices. There were no constitutional symptoms, and Mrs. MD was a normotensive lady, non-diabetic. Physical examination revealed palpable purpura on the legs, and I have shown you the clinical photographs. Her cardiorespiratory examination was unremarkable. Abdominal examination revealed no organomegaly. Musculoskeletal examination was remarkable for the absence of synovitis or deformities. It was a normal joint examination. This was the data set that she brought to us. Her hemoglobin was 11, white counts normal, platelets normal, but ESR was 95. Her LFTs and the KFTs were normal, urine analysis normal, and she was euthyroid. She was carrying some autoantibodies with her, and these reports revealed rheumatoid factor was positive, anti-CCPs were negative, and she also had a ANA report positive, 1 in 3,200, strongly positive ANA. So we have a 41-year-old individual, long history, several years, purpuric rash on the lower limbs, joint pains, no fever, no constitutional symptoms, no bleeding from any of the orifices, high ESRs, and some autoantibodies were positive. Now, at this point, I would like to ask the PGTs who are attending, what investigations would they like to order? Please do type your responses, and at the end of the formal presentation, we shall talk about this. Would you like to do a skin biopsy? Do you think she merits a bone marrow examination? Or a Doppler of the lower limbs is warranted? Would you like to order a dsDNA or any other investigations? What we ordered were a double-stranded DNA, anchors, and antibodies to extractable nuclear antigens, the ENAs. The turnaround revealed she was negative for dsDNA. Anchors, both cytoplasmic and perinuclear, were negative, but her ENA showed positive Rho and positive La. SSA and SSB were positive. On direct questioning, there were no Sika features. However, a Shermer test revealed 2 millimeters, and for the non-initiated, the normal cutoff is 5 millimeters. So she had significantly dry eyes, and our final diagnosis was Sjogren's syndrome. And at this point, let me also mention that it's not Sjogren's, it's Sjogren's syndrome. Now, let's analyze this data set. So we have an individual presenting with purpuric rash, long history, joint pains, serologies which showed rheumatoid factor and ANA, and the ANA subsets were Rho and La. The patient did not volunteer history of Sika features, objective examination dry eyes, and this was Sjogren's syndrome. How would you treat her? Corticosteroids alone, disease-modifying drugs, a combination of DMARDs and steroids, antihistaminics, or any other. And I would want you to give your treatment options in the chat box before we move further. Now, please do feel free. I mean, it's what is important is your interaction. Now, if we look at the analysis of the data set, Mrs. MD had two basic complaints. She had joint pains, arthralgias, and she also had a purpuric rash on her lower limbs. Let's take these one by one. She had arthralgias, and arthralgias are joint pains without objective inflammation. The joint examination is normal. These are often non-specific, have several reasons. Post-viral, you could have arthralgias, whether it is chikungunya, whether it is dengue, whether it is corona. Overuse, repetitive use, exertion can be associated with arthralgias. Hyperthyroidism, hypovitaminosis D, the flavor of the season. Almost everybody in this country is vitamin D deficient. Then fibromyalgias, chronic fatigue syndrome. So joint pains are not uncommon, but these are arthralgias, do not have visible signs of inflammation, and separating arthralgias from arthritis is the important task of the clinician, and this is like separating the grain from the chaff. One important thing for all the students, non-specific does not mean inconsequential. And this is so very important, so very important. Let me give you an example. If you look at back pain, this is something which happens to all of us. In the vast majority of patients, it is non-specific, which means you cannot pinpoint any disc, you cannot pinpoint any caries, you do not have multiple myeloma, there are no mets sitting there, and it's non-specific. But it can be terribly painful for the individual. So please do not mistake non-specific for inconsequential. What it means is that you cannot precisely pinpoint the reason for arthralgia. So that's why they are called non-specific. And non-specific is not the same as inconsequential. The patient may have a lot of symptoms. Now, arthralgias versus arthritis, separating the grain from the chaff. Let me take you back in time. And this is more than 2000 years old, something which is not available now. It's extant, as they say, no longer in print version. This is a treatise on medicine by one of the most famous Greek physicians, Aulus Cornelius Celsus. And on this cold wintry morning, let me talk about Celsus, Celsius, and Galen. Now, Celsius, all of us know, Delhi is hovering around 4 or 5 degrees in the mornings. This centigrade scale is named after the Swedish astronomer Anders Celsius, and this is very different from Celsus. And Galen was another equally famous Greek physician, came much later than Celsus. And these two individuals were credited with expounding or propounding the fundamental signs of inflammation that were taught to us in pathology: calor, dolor, tumor, rubor, warmth, pain, swelling, and redness, to which Galen added loss of function. So these two individuals gave us the 5 fundamental features of inflammation. And in arthritis, what you don't get, you get pain, you get swelling, but usually warmth and redness are not visible in chronic arthritis that you and I see in clinical practice. Rheumatoid arthritis, ankylosing spondylitis, the connective tissue diseases, if you are hunting for a red hot joint, more often than not, you shall never encounter it. The signs of inflammation are more subtle. You get swelling, you get tenderness, and you get loss of function. So where should a PGT expect to find a red hot joint? And there are only 3 situations in bedside medicine. Crystal arthritis, very dramatic presentation, a red hot joint. The patient may wake up with a big toe or an ankle or a midfoot which is swollen. Crystals, infection, septic arthritis, and then reactive arthritis. And with the exception of these, by and large, you would not get redness or you would not get raised temperature by and large. So When you are handling joints, you get some features of inflammation. And coming back to the core question, arthralgias are different from arthritis. Arthralgias, 101 reasons. Many a time you cannot pinpoint what causes that. Arthritis is when you have joint pains with objectively demonstrated loss of function, swelling, and tenderness. And sometimes, like in these situations, you get redness and you find that the joint is red and hot. At this point, I would also like to make one clinically important point. Arthralgias are different from paresthesias. Sometimes people mix the two, and you need to separate. And in clinical practice in rheumatology, be alive to carpal tunnel syndrome. So if you have a patient with arthritis, hypothyroidism, starts complaining of paresthesias, रात को हाथ झटकना पड़ता है, हाथ सो जाता है, make a search for carpal tunnel syndrome. Then polyarthralgia is not a diagnosis. Many a time what you find is that you write, this is a symptom. So polyarthralgia by no stretch of imagination is a diagnosis. So on the bedside, remember, when a patient presents with musculoskeletal pains, you could have the bursa being affected, bursitis, tennis elbow, you could have golfer's elbow, or you could have tendinitis, you could have fasciitis. One subset are arthralgias, and of arthralgias, some patients would have arthritis. So our patient, Mrs. MD, the 41-year-old lady who presented to us, had impressive arthralgias, but physical exam was normal. And this has a bearing on our case, as we shall see. The second symptom that she presented was purpura, which appeared and disappeared more when she was standing in the kitchen. So what is purpura? This is, as all of us know, a non-blanchable rash caused by a bleed into the skin, and based upon the size you classify it into petechiae, purpura, ecchymosis. Some books mention 4 mm, but the spirit is small pinhead sized petechiae. Slightly bigger, you call it purpura. When it's more than a centimeter, you call it ecchymosis. But from a teaching learning perspective, on the bedside, you categorize your purpura into palpable and flat or non-palpable purpura or macular purpura. And this is important. Why this is important is because it helps you to narrow down the list of differential diagnoses. And if you look at causes of purpura, flat purpura, hematological disorders like thrombocytopenia, platelet function disorders, clotting disorders. And as we grow older, the older population would have some kind of, what is called senile purpura, skin fragility. Steroid-induced purpura is flat, and then something which is less common, scurvy. All these is flat purpura. So this is a simple thing that you find that when you run your hand over the skin, non-palpable. When you talk of palpable purpura, as Mrs. MD had, you are dealing with autoimmune rheumatic diseases, infections, drugs, and in some patients you cannot pinpoint. And drugs could be antibiotics like penicillin, cephalosporin, sulfonamides, diuretics, a whole list. And in our country where infections are galore, hepatitis B, C, rickettsial infections, meningococcemia, gonococcemia, all of these could be associated. And this is one example. This is a young lady who had fulminant meningococcal infection. You can see this is called purpura fulminans. So whenever you have purpura, it's a good idea to run an infection screen for Hep B, C, and HIV. And many a time you are rewarded. And this is a flat purpura, steroid-induced purpura or ecchymosis. And in the elderly, because of the laxity of the skin, you get senile purpura. So these are examples. And then hematological causes like autoimmune thrombocytopenic purpuras are all flat. Now this lady, Mrs. MD, had a palpable purpura with joint pains. And if you look at the data set, she had a ESR of 95, and this is her serologic signature. Rheumatoid factor positive, ANA positive, ANCAs negative, Rho and La positive. I must also tell one thing. Don't forget infective endocarditis. That is the subject matter of many a CPC, and I can see Amal Das sitting there. Infective endocarditis can be the Waterloo of many a physician. RF can be positive, low titer antibodies can be positive, your cardiac examination may be unremarkable, and your echo may miss it. And once in a while, you find that, it springs a surprise on you. So anyway, that's about infections. Now, this is her serologic signature. And if you look at the autoimmune rheumatic diseases that trigger palpable purpura, this is a listing, Hanoch-Schönlein. And as we move away from eponyms, it's now called IgA vasculitis. Then we have the ANCA-associated vasculitides, in which we have GPA or Wegener's, EGPA or Church-Strauss, microscopic polyangiitis, which has no eponym associated with that. It could be lupus, it could be Sjogren syndrome, and in rheumatoid arthritis, the only setting where you get purpura, nail fold, infarct, skin necrosis is rheumatoid vasculitis. Let us analyze our patient. Now, Hanoch-Schönlein is serologically bland. And if you look at our patient, she had antibodies. With Hanoch-Schönlein, you do not have antibodies. 40–50% patients' IgA levels may be elevated, but the presence of rheumatoid factor, ANA, Rho and La militate against the diagnosis of Hanoch-Schönlein. Now, what about the ANCA-associated vasculitides? As the name suggests, they are associated with ANCA. Our patient was ANCA negative. She had strongly positive ANA, 1 in 3,200, very, very strongly positive ANA, and ENA showed Rho and La. So this is not the serologic signature of ANCA-associated vasculitides. Now, if you look at lupus versus Sjogren's, there was no history of malar rash, no photosensitivity, no fever. She had a ANA positive, which brings us to the important point that ANA does not mean lupus. ANA is the serologic hallmark of many connective tissue diseases. So dsDNA is present in about 60% of lupus patients, not in all. But the absence of photosensitivity, the absence of malar rash, the absence of fever, the absence of dsDNA, and with intermittent rash appearing and disappearing, lupus is far less likely in this individual. What about rheumatoid arthritis? As I mentioned, her joint examination was unremarkable. Rheumatoid vasculitis happens in the setting of long-standing rheumatoid. The joint disease leaves its telltale imprints. She had no synovitis, no deformity. With rheumatoid vasculitis, nodules are present. And you can have mononeuritis multiplex. You can have other stigmata like corneal involvement, scleritis, peripheral ulcerative keratitis. She had none of these. And with an impressive history of 7–8 years with a normal joint exam and no evidence of rheumatoid stigmata, I would be extremely reluctant and very high ANAs to call it rheumatoid arthritis. So if you look at the data set, arthralgias, palpable purpura, there are no signs of rheumatoid arthritis. So rheumatoid is not something that you would entertain on the bedside. Lupus versus Sjogren's, even if you don't have serology, detailed serology, the absence of photosensitivity, sparing of the photo-exposed areas, and purpura which comes and goes, I would think I would place Sjogren's on the higher part and lupus down the line. And of course, then we confirmed it with ENAs. Sjogren's is of two types, primary and secondary. Secondary occurs in the setting of rheumatoid, lupus, and scleroderma. The final diagnosis in our patient was primary Sjogren's syndrome. And let me now briefly run you through Sjogren's and the approach to connective tissue diseases. This is an eponymous syndrome. Henrik Sjogren was a Swedish ophthalmologist. And one of the key messages for the PGTs is Sjogren's is not esoteric. It is not exotic. It is not uncommon in India. And if you look at the spectrum of CTDs, lupus, Sjogren's, scleroderma, UCTD, in terms of commonality, Sjogren's is perhaps far more common than lupus. It is nearly as common as rheumatoid arthritis, but the problem is the inability to connect the dots. The person presents with dry eyes, lands up with the ophthalmologist, look at the caries, unusual sites of caries, extensive caries, dry mouth, and the patient goes to the dentist. The dentist does not think that it is Sjogren's, and you can see no salivary pool here. And some of them have parotid swelling, some have Raynaud's, others have palpable purpura, land up with the dermatologist, and this is nephrocalcinosis. This inability to connect the dots is the reason why Sjogren's is not picked up. Some of them go around with rheumatoid factor low level positive, are erroneously labeled as rheumatoid arthritis. And if you have an impressive history of rheumatoid, no deformities, many of these cases might turn out to be, if you scratch the surface, they could turn out to be Sjogren's. So multiple specialties, inability to connect the dots, and this is where the role of an internist is very, very important. You are uniquely placed to connect the dots because you are tuned to handling multi-system disorders. Then key message number 2. Eliciting history of Zika symptoms requires skill. You ask them, aankhon mein सूखापन to nahi hai? You will get an answer no. But if you ask them, do you rub eyes? Do you need to have your vegetables with gravy or water while you eat food? And the answer may be yes. So you have to ask them that, are you able to eat toast? Can you take food without water? And you will get a positive much more than if you ask them, muh mein सूखापन to nahi hai. Then remember, dry eyes, dry mouth, purpura have several causes. Dry eyes, contact lenses, ambient environment, all of these could give rise to dry eyes. Diabetes, then you have anxiety, lot of drugs can give rise to dry mouth. Purpura causes I have discussed. Raynaud's have several causes, and parotid, mumps, diabetes, alcohol, HIV, sarcoid, all of these. And this is what makes the task of an internist fascinating and challenging. Now, in the next 15 minutes, I'm going to run you through the concept of connective tissue diseases. This is no prizes for guessing this one. This is the malar rash, so typical of lupus. And this is the Mount Sinai School of Medicine in New York City. And for those of you who may be wondering about the link between these two seemingly disparate things, you need to travel back in time. This was Paul Klemperer, Austrian pathologist working at Mount Sinai School of Medicine, who first enunciated the concept of collagen vascular diseases in 1941. They could not explain these diseases based upon the concept of single organ involvement. but he was a man with a remarkable prescience. He said, this is a term liable to be misused as a waste paper basket for maladies with puzzling clinical and anatomic features, and he was so very right. These days, if you don't understand anything, call it a collagen vascular disease, which isn't actually true, as I shall show you. The preferred nomenclature now is connective tissue diseases. Collagen is one part of CTD. So we now use the term CTD rather than collagen vascular disease. This is the spectrum. The serologic hallmark is ANA. Sjogren's perhaps more common than lupus. Flagship disease, dramatic in presentation, multi-system involvement, lupus. Then we have a challenging cousin, systemic sclerosis, and UCTDs, MCTDs. Some people also include APS in it. So this is the universe of CTDs. The purists would exclude the vasculitides and the arthritis from the universe of connective tissue diseases. From a teaching learning perspective, when a PGT has to approach a CTD, you have to ask yourself 5 questions. No more. Am I dealing with a CTD? If so, what is the type? How should I investigate this patient? What organs are affected and how best to treat? Is this a connective tissue disease? We rely on pattern recognition. Multi-system disorder, especially in young women. When you have a picture which looks like rheumatoid arthritis, but with additional features like fever, active urine sediment, prominent cutaneous manifestations, think in terms of a CTD rather than rheumatoid arthritis. Some present with polyserosal involvement, ascites, pleural effusion, think of conditions other than tuberculosis, other than lymphoma. FUO may present with fever of unknown origin, may present to the nephrologist with unexplained renal failure, pulmonary renal syndrome, mononeuritis multiplex. Important causes, diabetes, Hansen's, your malignancies like lymphomas, and then of course CTDs. May present with pancytopenia. ITP may be the first manifestation of lupus, may present with Raynaud's, and may even present to the psychiatrist with psychosis in a young female. And the teaching is, when you have ITP with splenomegaly, think in terms of lupus. And these are some clinical photographs, prominent malar rash, and mind you, Mrs. MD had rash on her legs. She had no photosensitive rash at all, which is why I placed in the differential diagnosis Sjogren's over lupus. These are some examples: oral ulcers, you can see cutaneous vasculitis, and lest we forget, lupus also happens in males. Elderly onset lupus also happens. It's not exclusively confined to women. Jacob's arthritis, where you have a picture now. In olden days, rheumatic fever was the #1 cause of Jacob's arthritis, no longer now. Correctable deformity, no erosions on x-rays. The picture looks like rheumatoid, correctable deformities. That's Jacob's arthritis of lupus. This is Raynaud's phenomena. And with Raynaud's phenomena, the CTD that should come to your mind is not lupus, but scleroderma. You can see nail pits, calcinosis, telangiectasia on the face, and telangiectasia and finger pits, think of scleroderma. Hidebound skin, think of scleroderma. Pigmentation, depigmentation, think of scleroderma. So you need to have a sense of smell to smell these CTDs. Then we come back to our template. What is the type of CTD? And I've told you that Sjogren's, lupus, then we have overlap syndromes, MCTD, scleroderma, and there are several classification criteria which confuse more than they convince. And let me now demolish the myth of classification criteria. They are a strain on memory. Nobody can remember these criteria at all. And this is one example. Lupus Classification Criteria 2019. And the important point from a clinical perspective is criteria accrual takes time. When patients present to you, they may not fulfill all criteria. And with lupus, the time could range from 2 to 25 years. So you have to remember that there are two kinds of criteria: classification criteria and criteria for diagnosis. What you have are classification criteria applicable to groups. By nature, they are more specific. So if you have a study between Siliguri Medical College or Burdwan Medical College and Calcutta, you need a homogeneous patient population. You need classification criteria. But when you are sitting in your clinic, you need criteria which are more sensitive, and most of the criteria are classification criteria, not diagnostic criteria, although they are used as surrogates, and nothing ever replaces the reasoned judgment of a seasoned clinician. So criteria are a trade-off between sensitivity and specificity. To homogenize your population, you need specific criteria, but on the bedside, you need not to miss a single patient. So there is a distinct difference, and I'll show you this case vignette. This is a lady who presented with malar rash, no other complaints. And you look at her classical rash, she was ANA positive. And such a patient would be diagnosed as lupus. It's a no-brainer. But when it comes to classifying her, since she is not meeting all the criteria, you would exclude her from a clinical study, from your research study, from your thesis subjects, because she is still not categorized based upon classification criteria. So the important thing is treatment should not be delayed pending classification. The classification criteria are adjuncts, not substitutes, for a rational clinical judgment. And what is more important is to delineate organ involvement and get the treatment going. You don't tell the patient, Lagta to lupus hai, but you don't fulfill the criteria, so you go back and return in 6 months. Absolutely not. So it is important to differentiate classification from clinical criteria, and most criteria are classification criteria. When it comes to diagnosis, you have to use your gray cells. What about UCTD, MCTD, and a definite CTD? And let me simplify this. This is the jargon that is employed. When diseases begin, they may not have the full-blown phenotype. You could have a patient with fever and some malar rash. You cannot categorize that patient as a lupus or a scleroderma. Such a constellation is called undifferentiated connective tissue disease. And three things happen in clinical rheumatology: evolution, resolution, and persistence. This patient may go on to pick up more features, and then you can say 6 months later has a definite connective tissue disease, or may, in the lucky ones, resolve, or may stay undifferentiated. So you can have the entire scenario undifferentiated, evolution, or resolution, and this is a function of time, which is why you don't delay treatment. You treat for what you see today, and what you may call as lupus today may down the line pick up features of scleroderma. What about mixed connective tissue disease? Now, there is a lot of confusion going about this, and people use this label very casually. This is a serologically defined subset of overlap syndrome. When you have bits and pieces of multiple connective tissue diseases, you call it overlap. That's the clinically preferred term if you do not have access to serology. MCTD is serologically defined. You need to have antibodies to U1 RNP before you call it MCTD. All MCTDs are a part of overlap, but not all overlaps are MCTDs. And if I have to give you an example, all cardiologists are physicians, but all physicians are not cardiologists. So if you do not have access to serology, we are a poor country, people cannot get ENAs done, you use the term overlap syndrome. Should you be able to identify U1 RNP with puffy fingers, you start calling it a MCTD. So the broader terminology is overlap. Everybody is a physician. Some are cardiologists, some are gastroenterologists. So MCTD is a narrow subset. Coming back to the template, question number 3, how should you investigate? You need ANAs. ANAs do not mean lupus, and I showed you the example of Mrs. MD. Multiple reasons, Sjogren's, MCTD, rheumatoid low titers, infections can trigger it. And these are the subsets of ANAs or ENAs as they are called. dsDNA is present only in 60% and is a surrogate for renal lupus. It's very specific but not sensitive. So remember one thing. I'll take 5 minutes to wind up.
No.
Sorry,
Go on.
please continue.
Dr. Pathak,
Pathakda,
please mute yourself. Go on.
ANAs are positive in 99% of lupus patients. ANA negative lupus is surprising, but dsDNAs are positive only in about 60% people. So this constellation, ANA positive, dsDNA negative, is not surprising. But if you have the reverse, ANA is negative and dsDNA is being positive, you should be extremely reluctant to accept this. And this is more often than not because your test methodology is picking up single-stranded DNA. So this kind of constellation, be reluctant to accept this. Investigations other than autoantibodies, urine examination. You should be obsessed about urine when you talk about CTDs. It tells you about the sediment, whether kidney is involved or not, proteinuria, cells, casts, all have to be looked at. Apart from this, these are the other investigations. You quantify the proteinuria, you look at complements. Now let's return to Mrs. MD, our index case. I haven't seen what you have typed in the chat box, but skin biopsy, would it help? Well, a skin biopsy would end up by confirming that we are dealing with leukocytoclastic vasculitis. No big deal. I mean, leukocytoclastic vasculitis, when I can see a palpable purpura, that's what I expect in histology. It has no discriminant value, does not tell me what is causing the disease. So I would not, really speaking, order a skin biopsy. If resources are not an issue, you need to document it, all right. Bone marrow examination, unlikely to help in our patient because hematological parameters were normal. Venous Doppler, we are not suspecting venous insufficiency here, no role. dsDNAs, certainly yes, they should be ordered in patients who are positive for ANA, are used as a surrogate for renal lupus and for monitoring disease activity. And other investigations I've already mentioned that we ordered ENAs which were rewarding, which helped us to pinpoint the type of connective tissue disease. Now, to come back to our template, these are the 5 questions that every PGT needs to answer. The next question is, after investigation, what organs are affected? This has a bearing on treatment. And giving you the example of lupus, you divide it into major organ, you divide it into minor organ involvement, and with major and minor, because this reflects treatment need. Mind you, for a teenager, a lupus rash, which we call as minor, may be emotionally devastating. So again, like non-specific does not mean inconsequential. Minor involvement does not mean it is any less important for the individual. This is a way of categorizing the treatment need. Major is kidney involvement, neuropsychiatric lupus, significant cytopenias, cardiopulmonary involvement, myocarditis, ILD. Minor are fever, fatigue, joint pains, and skin and serosal involvement. And why do you divide it? so that you can decide on the quantum of treatment. And this is one of my favorite slides. Lupus as a diagnosis. If you reach the diagnosis of SLE in a patient, your job does not end, it begins. And if I have to borrow from Amalda's specialty cardiology, it is like rheumatic heart disease. With rheumatic heart disease, you need to tell people, is it a stenotic lesion, regurgitant lesion? What is the NYHA class? Are there complications of infective endocarditis or rheumatic activity? Much in the same way with lupus, you need in a complete diagnosis to mention the organ involvement, the type of nephritis, comorbidities like hypertension, dyslipidemia, blood pressure and all very important. And then finally, activity versus damage, which are so very important in chronic diseases. You could have an active disease today, 6 months later goes into remission, and 16 years later may have substantial damage where you need to back off. And let me tell you, this is very, very important. A diagnosis of lupus is just like saying somebody has a valvular heart disease. Means nothing to a cardiologist. So you need to pinpoint organ involvement, type of organ involvement, comorbidities, activity versus damage, and disease activity reflects the inflammatory burden. You need clinical evaluation, urine examination for red cells, CASH and proteinuria, dsDNA, complements, and acute phase reactants. Repeated ANA testing has no role, and disease damages when you back off. Which are non-reversible changes present for 6 months, and in contradistinction to activity which is reversible, this is non-reversible, and I've listed some examples. If you have honeycombing of the lungs, you need to then, and very less of alveolitis, you need to back off. Go slow on immunosuppression. Class 6 lupus nephritis needs renal replacement therapy, does not need cyclophosphamide. When you have cardiomyopathy, you need decongestant measures, ACE inhibitors, you need to rope in your cardiology colleagues. But if you have lupus myocarditis, you need to be aggressive. So you need to classify at any point of time how much is the inflammatory burden versus damage. So, and you do it all the while. So if you have rheumatoid with osteoarthritis knees and the hands are all quiet, kilos of methotrexate will not help the osteoarthritic knee. So you have to differentiate activity from damage in connective tissue diseases, and I use the example of lupus. And lastly, how best to treat, and this is where you need to delineate organ involvement. The treatment of nephritis is very different from arthritis. Intensity of treatment is titrated to disease activity. Don't forget comorbidities like cholesterols, triglycerides, bone health, hypertension, and by no stretch of imagination do you offer steroids high dose to everyone with CTD lifelong. Unfortunately, many people have grown with this mindset. CTDs are 40 milligram prednisolone lifelong. It isn't true, which is what brings back to minor and major organ involvement. Minor organ involvement, you may not need steroids. Should you need it, you need modest dosages, 0.25 to 0.5 milligram per kilo of prednisolone, 5, 10, 15 milligrams. And with major organ involvement, induction is with high dosages, 40 to 60 milligram. Once they get better, you reduce it. Once they go into remission, even these people can do without corticosteroids. So at every stage, you assess activity and modify your disease dosaging of drugs to match the disease activity. And you require much more of azathioprine, cyclophosphamide, MMF with major organ involvement, whereas hydroxychloroquine is offered to all. And this is what you mean by major and minor organ involvement. Coming back, and this is my last couple of slides, coming back to Mrs. MD. She had arthralgias and she had a palpable purpura. non-itchy rash. What did we do for her? We offered her hydroxychloroquine. We offered her lubricant eye drops. Her symptoms were not suggestive. She did not complain of dry eyes. This is what we offered her. Told her that if she does not get better in terms of joint pains, we might consider adding methotrexate. And if it flares up, occasional corticosteroids. She had no major organ involvement, and this is what we offered to her. Friends, I would like to end my presentation by mentioning connective tissue diseases are multi-system diseases. Internists are uniquely placed to assess them. The single most important thing is physician awareness. All these criteria that we talk about are adjuncts to, but not substitutes for your reasoned judgment. Labels don't mean much. You need to delineate organ involvement and treat accordingly. Serology in isolation can at times be misleading, and the dictum is treat the individual, don't chase the serology in the disease that is CTD. This is where I end, and as Dr. R.N. Sarkar Dada already showed, this is with the culmination of years of clinical practice, clinical rheumatology. If this has stimulated your interest, thank you very much. And now I shall be happy to take up questions.
Thank you, Professor Handa, for the nice presentation. Now, I think most of the PGTs now will be able to differentiate between this CTD, which is quite commonly loosely called. Any patient coming with this rashes, with joint pain, and they call it, let us go for a collagen panel or this connective tissue disease panel. And that I think the PGTs are now quite, now what is the, I think, would you kindly elaborate something more on the UCTD, because the UCTD is the most important thing which we come across in our the initial presentation.
Absolutely. Actually, you see, diseases don't read textbooks. We do. So whenever a system is, a disease is evolving, they are usually polysymptomatic, or they have poly-organ involvement, and they may be monosymptomatic. So what you have are a few symptoms. So if you have a setting like fever, joint pains, but serologic hallmark has to be there, ANA positivity, you call it a undifferentiated connective tissue disease, which means that the ANA shows that you are dealing with a connective tissue disease, but the patient is not having the full clinical spectrum of SLE, is not having Raynaud's, is not fulfilling. I mean, different people, some will come with Raynaud's and ANA. So what I'm trying to say is that you have the disease onset with features in bits and pieces of a CTD, not the full-blown picture. With serology of ANA, you call it an undifferentiated connective tissue disease. And to give you some examples, some people may come with Raynaud's phenomena and a positive ANA. And for 20 years, they have no features of skin thickening, skin tightening, and they have no features of scleroderma. So rather than calling them scleroderma, you would call them undifferentiated connective tissue disease. Give them treatment according to the organ that is affected. So if it is Raynaud's, I would offer calcium channel blockers, ARBs, protection from cold. But just because it is Raynaud's with ANA, without organ involvement, I would not call it scleroderma. 10 years later, 15 years later, some evolve. And then 20 years later, what you call as UCTD may soon turn out to be scleroderma. And this is also seen in psoriatic arthritis. Yeah. What I label as seronegative rheumatoid arthritis, 5 years later, they develop a patch of psoriasis on the scalp, and you revise your diagnosis to psoriatic arthritis. So when a disease begins, not everybody gets a full-blown picture. Some get full-blown picture, all features at the same time. Others start with a few features, NA positivity, that's called UCTD.
Yeah, thank you very much.
There
Now,
are some questions, sir, if you permit, can I answer?
Yeah. I will first go with the one with Dr. Bodhisattva Banerjee. Incomplete lupus, how does it differ from UCTD? Incomplete lupus.
Well, it's a question of nomenclature. UCTD is a all-encompassing concept. So incomplete lupus means that you have pronounced somebody with lupus ki isko to lupus hoke rahega. UCTD allows you the liberty. It may go to the track of lupus, may evolve into scleroderma, may evolve into overlap syndrome, and for all I know, may also develop a overlap with myositis. So a preferred nomenclature is not incomplete lupus. The preferred nomenclature is undifferentiated connective tissue disease. And they say that in the earlier times, Dame Carol Black used to say that pre-scleroderma. When you have Raynaud's with ANA and some nail fold capillaroscopy, it is devastating for the individual. Incomplete lupus, the person lives under the shadow of fear ki lupus hua. No, it's not true. So incomplete lupus is no longer employed. The preferred term is UCTD.
Yeah. It should not be diagnosed, actually, not written. Incomplete lupus,
And there are some other questions in the chat box also.
Yeah, other question is regarding not our topic today. Can rheumatoid arthritis present with positive RF and negative anti-CCP?
Yes, you have 4 clinical scenarios in rheumatoid arthritis: double positive, double negative, single positive. So you could have RF and CCP being positive, both being negative, and you could have either RF or CCP being positive. So 4 scenarios happen. Overlap syndrome is next question. When you have, say, features of lupus and myositis, the patient has muscle pains or muscle weakness, CPK may be going up to, say, 3000. So this is the overlap syndrome, and as the name indicates, that there is an overlap of 2 connective tissue diseases. Clinical pointers are whenever you have features which you cannot explain with a single disease. For example, if you have lupus with finger pits and very prominent Raynaud's, I would start thinking in terms of a lupus with scleroderma overlap. When you have prominent muscle weakness in scleroderma, I would start thinking in terms with scleroderma with myositis overlap. Clinical pointers are anything which is not the garden variety of clinical features with a overwhelming pointer towards. So if I get erosive features of rheumatoid and I get a malar rash and I get fever and hair loss, but a arthritis which is deforming with erosions, that is rheumatoid lupus overlap.
Another question, does seronegative RA exist? Yeah, of course, it exists.
Well, according to the current state of knowledge, it reflects inadequacy of our knowledge. Maybe by the time the PGTs become distinguished professors, there will be nothing left as seronegative. But as of today, what you cannot pick up by technology, I mean, yes, today it exists.
IgM only, maybe. Now, there are one question from my side. We have seen many cases where there is psoriatic arthritis phenotypically. Rheumatoid factor is also positive.
And you can have both things. Sir, you are an astute clinician. You have 2 things happening. Just like chikungunya person can get dengue. Nature knows no boundaries, and you could have rheumatoid and psoriasis coexisting. You could have CCP positive rheumatoid with florid nail changes of psoriasis. You could have angst-pond and rheumatoid. You could have rheumatoid with gout in the same individual.
And the Hansen arthritis also presents.
Hansen's is something, sir, which can come in all shapes and this. My concept of Hansen's is poor. I grew up in Punjab, where, you know, the first Kala Azar in my life I saw when I moved to Delhi many years ago. I mean, I'd never seen Kala Azar in my life. And when I landed at AIIMS, everybody with spleen and fever and LD bodies and this. So, I mean, Hansen's is something which is very much there and should figure in the differential diagnosis.
It can present as CTD also. Myositis.
Occasionally, ANA positivities can be seen in a whole variety of things. There
Now
is a
I'll-
question on repeat renal biopsy.
Oh, yeah.
Well, dsDNA, the attendee would like to know about dsDNA and repeat renal biopsy. Well, repeat renal biopsy, dsDNAs are surrogates. You cannot put a needle into the kidney time and again. So how do you assess improvement? You look at urine. You look at whether the RBC casts and the red cells are disappearing and the sediment is becoming bland. You quantify proteinuria with a 24-hour urine protein or a spot urine protein creatinine ratio. And the third surrogate is your dsDNA. And of course, your complements. So your dsDNAs fall, complements rise. So these are surrogates for this. Renal biopsy is ordered repeat when you are suspecting class transformation. I have a person, say, who's membranous, and suddenly I find that the RBCs are present in the urine, the proteinuria is not settling, casts are appearing. So when you are suspecting class transformation, when there is inadequate response to treatment, when you have reason to believe the person could have developed amyloid and it is no longer lupus which is bothering you. So that is when you do a repeat renal biopsy. It's easier to use surrogates like urine sediment, quantification of protein complements, and dsDNA. If cost is not an issue, all lupus nephritis should get a dsDNA and complement on every visit. But renal biopsy is only when you have suboptimal response to treatment, significant renal response, a relapse, when you are suspecting class transformation.
One question from Dr. Ganguly, that is Aritra Ganguly. What is the correct method to detect ANA?
Good question. Immunofluorescence, because the anti-nuclear antibodies have several antigens. Some are poorly characterized, some are well characterized. So ELISAs do not match up. Immunofluorescence, but quality of the lab has to be very good. Now everyone is setting up an immunofluorescent ANA, and what you get are 1 in 40, 1 in 80 labs, which mean nothing. And the label of lupus is indiscriminately employed. In contradistinction to ANCAs, where the antigens are well defined, proteinase 3, myeloperoxidase. So ELISAs are now preferred in ANCAs rather than immunofluorescence. With ANAs, you should ideally use immunofluorescence. But sometimes what happens is where you have a dubious ANA, I prefer to combine it with ELISAs, but technically immunofluorescent ANAs.
One question from my side, you please clarify to all our PGTs and would-be internists that all patients who are coming with some vasculitic rashes, particularly in the lower limb, should they be subject to ANCA test?
Well, generally speaking, I'm quite parsimonious with investigations. Unless I have a clinical feeling that there are constitutional symptoms, I would run an infection screen on almost all, hepatitis B and C. I would ask for a urine examination for everyone. Simple investigation, widely available, but ANCA only if I have reasons. If the rash is not settling down, if I find that I have drawn a blank everywhere, then I would order an ANCA. So I would actually not rush to order a panel for everyone. One has to learn to kind of, we should be sensitive to the resources. And for people, if we order ANCAs and ENAs for everyone, I think it's not possible in our country.
Yeah, thank you. Now, any question from other learned members of the panel? Senior
Thank you, Rohini. Thank you, Rohini, for your wonderful presentation. And you have been praised knowledge and a stimulus to read more. Now, I will share one of my experience that Sjogren's going to a nephrologist. This patient first presented with polyuria and went to a nephrologist, and he diagnosed it as a case of nephrogenic diabetes insipidus. Then ataxia developed. He went to a neurologist, and neurologist admitted him. Now the hospital where I am working, that is neurological indoor. So it was admitted under me. And the very day now, my PGT told me, sir, a patient of Sjogren's was admitted. I don't know how will I confirm a patient of ataxia Sjogren's? Sir, in the previous hospital, they performed the ABG. The potassium is low and the body pH is acidic. And you told us it can occur only renal tubular acidosis, and the most important cause is Sjogren's. And I performed SSA, RO and LA, and it was positive. And that time, I first came a patient presented first with polyuria and then with ataxia, and the case is Sjogren's. Now the Sjogren's have 4 type of classification. You know it better than me. The first is the glandular, second with mild symptom, third with major organ involvement, and the last is lymphoma. So our knowledge of Sjogren's is daily increasing, and it is very difficult to differentiate private Sjogren's from SLE. Is it essential? I think essential, because if I stamp it as a SLE, then chances of renal involvement is more, and I am to guard. If it is Sjogren's, I see renal involvement is not that much, but treatment may be in the early stage, may be same. So Sjogren's may be more incidence than SLE in future, but our knowledge, understanding, and inquisitiveness for Sjogren's have to be increased, and you have stimulated us to read more about Sjogren's and think about Sjogren's. Thank you very much.
Thanks, Dada.
Can I make
Very
one
well
question?
echoed. Some of them present with renal tubular acidosis, some with peripheral neuropathy.
Yeah.
And when you investigate the peripheral neuropathy, the Sika symptoms are polysymptomatic. Totally agreed, Dada.
Dr. Sarkar, can I make one question to Dr.
Of course.
Yeah.
You are
Dr.
welcome.
Handa, thank you very much for again teaching us in a great way, lucid way, and whatever I say, it's marvelous. But the 2 things I'm just wondering to ask you, whether significant morning stiffness in a patient of arthralgia can be a arthritis equivalence, because that's a problem for the clinician, particularly PGTs. So arthralgia with significant morning stiffness, without any signs of significant, dollar, tumor, or rubor, what you have talked, can it be an important issue? And my second question is the cardiovascular mortality and morbidity of institution of HCQS in CTDs. Has it remarkably improved the mortality morbidity as far as cardiovascular complications are considered?
Let me answer these questions one by one.
Yeah.
You're spot on when you say some people will never ever develop signs of arthritis. And when you have serologies which are positive with significant morning stiffness, and this is what we say, diseases don't read textbooks. If you have arthralgia with significant morning stiffness, it is prudent to order serologies, and if the person is rheumatoid factor and CCP positive, physical exam may always be unremarkable. But if you put a Doppler probe, you may still, that's why they use now ultrasound insonation as the extension. And in cardiology, they use it, Jagat Narula, the editorial with Eugene Braunwald, insonation, the 5th sign, inspection, palpation, percussion, auscultation. 100% yes. Some people never have clinically discernible arthritis, but they could have florid rheumatoid. And if you have an index of suspicion which is high, with high morning stiffness, investigate the patient. The second question is to do with hydroxychloroquine. and there is abundant data to show that it is the anchor drug for connective tissue diseases in terms of cardiovascular protection, mortality protection, lipid lowering, optimization of sugar levels. So every patient of a lupus, that's with lupus, not with scleroderma. It's widely employed in Sjogren's, but the maximum data set is with lupus. Should be offered hydroxychloroquine unless there is a cogent reason to deny them that. Then
Okay.
I noticed some questions
What-
on
yeah, yeah.
clinically active and clinically quiet serologically active lupus.
Yeah.
Clinically quiet lupus, which is serologically active, should be observed, and you benchmark your treatment to clinical activity, not serologic activity. Whether it is vasculitis or lupus, it is clinical activity which determines the treatment need, not serologic activity. And clinico-serologic discordance is well known, and serologic relapses may precede clinical relapses by months to years. There's a question
Dr.
from
Handa.
Devraj Chatterjee. Can methotrexate be safely given to a patient with scleroderma or MCTD with ILD as a complication? Most people now believe that methotrexate does not cause ILD, and it is the disease which causes ILD. And if there are reasons, you can use. If articular symptoms are dominating scleroderma or MCTD, you can use this. But if ILD is the predominant symptom, people would prefer mycophenolate, mofetil, or azathioprine. Methotrexate is primarily for articular symptoms, but should the articular symptoms be part of the symptomatology, there is no contraindication. Then there is another question on what will be the treatment approach of CKD with primary Sjogren syndrome, and renal biopsy could not be done. Well, it's usually interstitial nephritis, which is the reason. You need ideally to look at the kidney size. Normal sized kidneys, if resources permit, should all be subjected to a biopsy, because sometimes the histology is surprising. And if it is not a glomerular disease, interstitial disease, most people would still prefer to give the doubt and use corticosteroids and mycophenolate mofetil. Ritux is also widely employed, particularly with biosimilars of rituximab being available in the country.
Yeah. Another question from Dr. Mukherjee. Pedal edema, erythema nodosum, ANA positive, paratracheal, parahilar lymph nodes, regress spontaneously. What will be the diagnosis?
The first diagnosis should be with parahilar lymph nodes, and hilars should be sarcoid. ANA doesn't impress me. I mean, ANA could be there with a clinical correlation is mandatory. If you have features of erythema nodosum, hilar adenopathy, you should have reasons to think of diseases other than sarcoid. Low titer ANA can be present. What I would do is I would try and get an EBUS and a lymph node to see what is happening inside. Granulomatous lymphadenitis without AFB, ACE levels may or may not be elevated. I would think in terms of sarcoid. And ANAs, I can also always do a ENA or a line immunoassay. And if ANAs are positive and ENAs are totally negative, that can be compatible with sarcoid.
But it regressed spontaneously. The another paratracheal.
Well, more likely to be sarcoid. Regression is more a feature of sarcoid.
Yeah, maybe. I think there are no other questions of importance.
Well, I must thank you for the learning opportunity.
No,
I mean,
we have learned
so much. And the googly by Dr. Ganguly and Dr. Ghosh, these googlies, this is what is clinical medicine. We learn from each other.
But Sjogren is really is coming. We are seeing a lot of patients.
Rohini, at this age, what we want is stimulus for learning.
Sir, a pleasure. When Amalda phoned me, I said I would be delighted to join. I mean, rather than, and this case-based format that you have started is amazing.
Yeah.
I mean, this is how people present, patients present. They don't come and say, look, I have this disease, now treat me. So this is an amazing format where I must compliment West Bengal chapter for this.